I want to move us on now to where are we going to go from here, and maybe some of your predictions for the future. Ted, I'll go to you. Is the employer-based healthcare insurance system an individual small group market here to stay, or do you think we'll ever see a Medicare for all solution? And I know that's a very loaded question.
Well, I think it's fair to say that if we were beginning our healthcare insurance delivery, provider delivery model today, we would not create the system that we have in place right now, where you have self-funded plans, people getting, as Mark said, 60% of Americans getting their health insurance through their employers, and everyone else more or less through the small markets or through government pay. So I think that probably Medicare for all. You saw many a movement maybe 5 or 10 years ago to actually raise the age of Medicare eligibility, saying that it's going to bankrupt the country. Well, in our last election, you had some leading candidates for president actually talking about lowering the age of Medicare, and that got a tremendous amount of political support. So what I predict is perhaps a hybrid, like in the Part D model, and you have more of a Medicare for all, perhaps, where you have the government participating in a program and the private sector actually administering the benefit, much as the same way they do through Medicare Advantage and through Part D. I don't know, but I think that whether it's the endless fee for service model, cannot exist. And I think you have a surprising amount of agreement between Democrats and Republicans that we need to do more to advance value-based purchasing in our healthcare system.
I too don't see us moving away from our current pluralistic health system, having an employer-based component to it, absent a change in the tax deductibility of healthcare benefits. I do expect, however, that the current portion of employer-sponsored benefits may erode a bit, given the cost shift to employers as government, as it did in the Inflation Reduction Act, puts price caps on its own expenditures and leaves the self-fundeds more exposed to cost shifts. So that could cause us to see an increase in individual and enrollment in government-backed options. Given the difficulties in bargaining in the sector, which we've spoken about earlier, the knowledge imbalance that is inherent in consumer behavior in the healthcare sector, I agree with my colleague that the primary cost lever will be what we today are calling value purchasing, both for the ERISA plan and government healthcare programs, each acting through managed care company intermediaries. Back before Congress took away the Cadillac tax limits on deductibility, I thought that it would make policy sense to align the programs on value-based purchasing, to make exempt from a Cadillac tax those ERISA plan expenditures that would be made through a value-based purchasing paradigm. We may yet have time to see those sorts of measures introduced to further incent the development of value purchasing that we're speaking about today.
I just want to make one more comment about that. When I give speeches about Medicare, I always ask the audience, how come chronic renal disease is covered by Medicare? It's a disease state. It's not a age or anything. And it has to do with the politics of that time. I do think I'm all about patient cohorts. When the government covers a population, it's both the insurer and the reinsurer. When the commercial market covers a patient, there's still a reinsurance market. I think that over time, the government is going to step in either as reinsurer or to identify patient populations where it is better for the federal government to be the payer or federal state share through Medicaid, because certain populations are predominantly Medicaid, certain populations are predominantly Medicare, but also there may be certain pockets of the commercial population that if we move them to the government payer side, we can make the commercial premium more affordable. I think the data is going to start to educate us which patient cohorts should be where. The other item I just want to mention is whether these exchanges really do grow and become stronger, like what Mark said, which is whether individuals will buy the health insurance because of either the fact that they're from small companies or because they want the flexibility not to be tied to their employer. And we'll have to wait and see if that infrastructure is there now, but we'll have to wait and see if people change their purchasing patterns around that.
This has been a really great discussion to see where the U.S. has been and consider where we're going as the country continues to balance the provision of healthcare with managing costs. As we close out the discussion, I want to ask each of you in 1 to 2 sentences, rapid fire, what is one prediction for what you think we will see in the next 50 years in the U.S. healthcare industry?
I'm not sure I can do 1 or 2 sentences rapid fire. After all, I am a lawyer. So I read biographies. I'm reading Louis Brandeis. He was a lawyer and a Supreme Court judge at the turn of the 20th century, before there was regulation like SEC, Federal Trade Commission, antitrust laws. He was instrumental in many of those new government entities and laws. I see the same thing happening with data. We will have a federal department of, I don't know the name, but it'll be data, privacy data, something around that. And what it will do is create that infrastructure that none of our current government entities currently have as a exclusive focus in order to have what we want as a democracy, the way in which we want our data to be shared, to be protected, regardless of whether it's personal health information or just our personal information. And that's because HIPAA was not designed to be anything more than protecting personal health information in connection with an insurance transaction. And personal information is straddled over so many different state and federal laws. So I also am working on artificial intelligence tools, anticipating how the government's going to regulate them. And I'm helping clients create compliance programs around these tools. And I think this government agency, whatever it's going to be, is going to regulate the AI tools as well.
Great. Mark, what are your thoughts?
I'll go back to the last point that I was making. I think it's inevitable that at some point Congress will look at the current sort of bank check tax deductibility of healthcare benefits and say it's time to align the purchasing by plans with the value-based purchasing being done by the Medicare and Medicaid programs. And they'll look to that lever in some form, Cadillac tax or otherwise, to juice, to further incent the positive developments in the system that we've been talking about.
And Ted.
Well, I believe that the trends towards at-home care promise huge dividends and cost savings for our overall healthcare system. There were things that were done only in the hospital 5 years ago that now services can be delivered in the home. So I think the trick is going to be how to get Medicare, Medicaid, and commercial plans to reimburse accordingly for this care.
Great. Mark, Lynn, and Ted, thank you so much again for joining us for today's show. It was a pleasure having you all here.
It was a pleasure reminiscing with Ted and Lynn. As usual, had a great run for 50 years, and we're looking for many, many decades ahead of continuing to wrestle collectively with the evolution of a very complex but absolutely essential system for our country.
And thank you to all of our listeners. If you like what you heard, don't forget to subscribe. Diagnosing Healthcare is available wherever you get your podcasts.